Hello, this is Dr. Bal. Welcome to Pharmacology. We will start with Chapter 1, Introduction to Clinical Pharmacology. These are the learning outcomes. Before we really get into our chapter, let's try to define the term pharmacology. Well, the term comes from Greek, where pharm means drug or medicine, and ology is a study of. So the definition would be pharmacology is a study of drugs. Now the question is, what is a drug then? Can anything that we take be considered drug? So try to answer this question. You can pause the video and see if you can answer the question. Can any substance used to either prevent, diagnose, treat, or minimize the symptom of a disease be considered a drug? I think so. I believe that anything that we put in our mouth or we take either IV or IM or even topically can be considered drug. Any substance that has a property to make chemical changes in our body, it can be considered drug. So having said that, how about a cup of coffee? If you have a headache, can a cup of coffee be considered drug? Or tea? Or spoon of honey? Would you consider spoon of honey a drug? So try to answer this question. You can pause. And I personally believe that the answer is yes. Perhaps if you have a sore throat or some other upper respiratory symptoms, and you are going to drink either a cup of tea or with a ginger in it, or take a spoon of honey, perhaps at that time that spoon of honey is a drug. So anything that minimize your symptoms or prevent the disease or has ability to make any chemical changes inside the body can be considered drug. Really brief history of drugs. You will never be tested on the history, but this is just FYI. We know that early humans started using either plants or herbs remedies to minimize symptoms of a disease. And Chinese and Egyptian have recorded herbal remedies in early BC. Indians have very well documented Ayurvedic remedies to treat either acute and chronic disorders. The modern pharmacology really began in early 1800s, and the main source of today's drug is plant-based, animal-based, minerals, and we also now make drugs synthetically. So you can pause for a second and try to answer this question. What would be an ideal drug? If you were to develop a drug today, what would you see? What would you like to see in that drug? What would be an ideal drug for you? And see if you can answer this question. I personally believe that an ideal drug should be the one that can effectively prevent the disease. If you cannot prevent, at least treat the disease. That would be an ideal drug. And also an ideal drug would be the one that works rapidly, quickly. If I have a symptom at 8 o'clock in the morning and I want to take a pill right now, and then I want to feel better at 8:01, it needs to work quickly. So that would be an ideal drug. The drug that requires a very low dose, and that's another beauty about designing another ideal drug would be that I shouldn't have to take multiple capsules. I shouldn't have to take a large dose because we know that when we increase the dosage, we increase the chances of side effects. So you want to minimize the side effects. So that's another point. The drug that produces no side effects or no adverse reaction, that would be an ideal drug. The drug that can be taken conveniently, and that is by mouth instead of injection, or either IM, sub-Q, or IV injection. Those are not convenient. You shouldn't have to schedule an appointment with a clinician to take the pill. We should be able to take the pill at home. The drug that can be taken infrequently. In other words, I shouldn't have to take the drug 2 times a day, 3 times a day, and so forth, or five times, 4 times a day, or for 5 days, 10 days. I should be able to take the drug. First of all, we shouldn't have to take the drug more than once. That would be an ideal drug. But if we have to take it twice, it should be taken infrequently. The drug that can be taken for a short length of time, so that's another neat property. The drug that is quickly eliminated from the body, and I really like that, because if you were feeling sick at 8 o'clock in the morning, you took the pill, by 8:05 you're feeling much better. Why is that drug still in your system? I don't need that. I don't need exposure to an unnecessary residual drug, a chemical sitting inside my body. We need to eliminate that as soon as possible, so that we can again minimize the side effects. So that would be an ideal drug. The drug that does not have any food or any other drug interaction. What do you mean that I cannot eat this food while taking this drug? Why can't I drink a glass of wine tonight if I'm on this antibiotic? So that's not an ideal drug. So an ideal drug would be where I should be able to eat whatever I want to, so that would be an ideal drug. The drug that is inexpensive. So here we are talking about a big concept, pharmacoeconomics. We know that drugs are very expensive. Some patients cannot afford to take these medications. So you shouldn't have to take a loan or sell your house to afford prescription drugs. So the drug that is inexpensive is an ideal drug. And drug that is easily accessible. Again, maybe over the counter versus prescription drug. Can you imagine if you're not feeling well, now you need to call the provider, make an appointment, and they tell you come tomorrow or later this evening, and you're miserable all day. You drive, you sit in the lobby for 4 hours before you can see the provider. They write you a prescription, then you take that prescription to the pharmacy. The pharmacy tell you, okay, well, we don't have that in stock, or it will take 4 hours to fill this medication, come back, we'll call you, and so forth. And so you can only imagine the patient who's suffering from the disease or the disorder or the symptoms that they have, wasted the entire day so that the patient can take that pill. So an ideal drug would be easy, accessible. You go, and then it should be sitting right there. You grab it, and then you feel better. Needless. This is an orange book. The orange book is a book that has both prescription and non-prescription medication approved by the FDA. The reason it's called Orange Book, by looking at the book you can tell the color is orange, and I believe, my understanding is, it was first released in the month of October, and when they had to decide the color of their book, they decided orange because that's the theme during that time, Halloween color, if you will. So anyways, it consists of all of the drugs that are approved by the FDA. Next, we are going to talk about drug nomenclature, and there are 3 ways to name a drug. The first one is a chemical name, and then we have a trade or brand name, and then generic. As you can tell by looking at the chemical name, chemical names are very long. It tells you what kind of chemical it is in the drug, and trade names are usually short and fancy. Generic names are given later on. We will talk about this in detail, but the slide that you have in front of you, you can tell that acetaminophen is a generic name for Tylenol, losartan is a generic for Cozar, and metoprolol is a generic name for Lopressor. So chemical names, as I mentioned earlier, each drug will have its own chemical name. It will tell you what kind of chemical it is. We do not prescribe medication based on chemical names. In other words, we don't use chemical names in practical world, if you will. These names are often difficult to remember or pronounce, so you will never be tested on chemical names. So the trade name or brand names are given by the pharmaceutical companies. Trade name is always, the first letter is always uppercase, it's capitalized. And these names are easy to remember, and what happens is when the pharmaceutical companies, when they develop a new drug, they will get protection, a patent protection for several years that other companies cannot develop the same drug. And once that patent expires, usually several years, when that expires, then other companies can use the same active ingredient and they can develop the drug, and we call that generic drugs. So generic, as I mentioned earlier, these names are easier to memorize. They're less complicated than the chemical names. Now these drugs are relatively less expensive than brand name, honestly sometimes significantly less expensive. And the reason behind that is, remember, brand names, brand drugs, those pharmaceutical companies, they have invested so much time and energy and money, millions of dollars, to get to do the research and get approval from the FDA. Now, whereas the generic companies, they will use the same active ingredient. It would have to be the same active ingredient that was already researched and well studied and considered safe for years and years. And generic companies are going to use the same chemical formula, and they may change the inactive ingredient. So therefore it's less expensive, and when you market a generic drug, you do not need all that full FDA. You don't have to go through FDA approval because you're not changing the active ingredient. So it's less expensive. The rule of thumb is that generic medications are as better as the brand name. One is not necessarily superior than the other. However, at the same time, we understand that when we change the inactive ingredient, it is possible that the way we absorb one medication may be different than the other medication. For example, there's a concept of bioavailability, and bioavailability means that it is the rate and extent to which the active ingredients are absorbed from a drug and then available at the site of action. Now, bioavailability pretty much means how much drug is available. So for example, when you swallow a pill by mouth, we know that 100% of that drug is not going to be available because of the effect of maybe hydrochloric acid in the stomach, and you have to go through the small intestine, and then you still have a liver in the way that you have to go through. So 100% of the drug is not going to be available to you, versus if this drug was IV, let's say. And we know that when we give IV drug, you can say that literally 100% of the drug can be available. So bioavailability of IV is always higher than the PO drugs. And then, so it's the same concept where the generic drug may have a different bioavailability than the brand drugs, because the rate of absorption may be different. Now, that does not mean, again, that does not mean that one is a superior than the other. It is a very well accepted practice to prescribe generic drugs. We actually encourage that. Generic drugs are cheaper, and as a matter of fact, in most states, pharmacists may substitute a generic for brand, even though laws vary state by state. But here in California, unless you write specifically that do not substitute, there's a box that you have to check. If you check that box that do not substitute, that means only I am going to write a brand name medication, and then the patient can only have a brand name. Then pharmacist cannot change. Otherwise, if that box is not checked off, it's okay. Even if you write a brand name, the pharmacist is going to substitute that brand name with generic. And we do that because we know that one is not superior than the other, and we know for sure that generics are cheaper than brand names. Many pharmacies offer a generic list to the patient, and so forth. Drug prototype. Prototype is a drug to which all other drugs in the same categories are compared. Most of the time, the first drug of a particular drug class that is developed is usually become a prototype. That simply means that other new drugs will be compared. That is usually the standard with which newer drugs in the same class will be compared. For example, morphine is the prototype of the opioid analgesic. So if you develop a new drug under opioid analgesia, that will be compared with the morphine. So if you have a pharmaceutical rep comes in to promote a new drug, that person is going to tell you why this new drug is better than morphine. So another example would be atorvastatin. Lipitor is considered a prototype for the cholesterol medicine, and we know that the penicillin is the prototype of the beta-lactam antibacterial drug. So again, usually these drugs are the first one that were developed, or a standard drug that other drugs will be compared against. So that's a prototype drug. Now, what are your responsibilities as a clinician? Well, number one, we really need to know why this drug is being prescribed to the patient. We need to know why. There has to be a good reason for a new drug to introduce. How this drug is supplied by the pharmacy. Is this a PO drug, or does it come with IM injection only? Especially if you have a patient at home who's not able to take injections. Is this a liquid versus does it come in a capsule, and you have a child who cannot swallow a capsule, or perhaps a geriatric patient who cannot swallow, or maybe needs to maybe you have a geriatric client with difficulty swallowing, and then the family tells you that we crush his medications. And does this medication come in a capsule form where they can open the capsule? Because if you are prescribing extended release medication, and you know that the family or the patient is going to crush the extended release, that is never a good thing. We are not supposed to crush extended release. You defeat the purpose. So it's always a good idea to know how pharmacy is going to dispense that medication, what is the form, um, how to give the medication, how to administer the drug, dose ranges. So in other words, 15 to 20 ml versus take 1 to 2 capsules. What is the direction? What is the route? Is it a suppository? Is it inhaler versus nebulizer? Always assessment is the first step. We should never ever be prescribing medication without assessment. Those are always the red flags. um, as a clinician, if you have a patient who tells you that I am in pain and I am here for pain refill, we should never write a prescription for that unless we have assessed. We have to do the physical exam, ask some more question. Where is the pain? What else can we do besides writing a prescription for pain? So these are our responsibilities. All right, so this was just our chapter 1 basic introduction, and email me if you have any follow-up questions. Thank you.